I'd like to run through the anatomy of the shoulder before we do the examination. But bony anatomy is the scapula, the clavicle, and the humerus. Here's the anatomy of the bony anatomy of the shoulder. The spinous process, above that is a supraspinatus, which inserts into the greater tuberosity. The infraspinatus, inserting into the greater tuberosity at the back. And you can see the function of the infraspinatus as it contracts would be to externally rotate the arm. The subscapularis, which arises from the front of the scapula and attaches to the lesser tuberosity, the front of the humerus. And when that contracts, the arm internally rotates. The supraspinatus is above the spinous process and attaches to the greater tuberosity. When the supraspinatus, which is attached here, contracts, the arm would abduct. The long head of biceps comes along the groove which is between the lesser tuberosity there and the greater tuberosity there. The reason for the demonstration of this anatomy is this makes examination of the shoulder and the particular muscles very easy to understand. The second thing I want to demonstrate to you is the movement of the shoulder joint. The shoulder joint moves in two planes. One is a scapulothoracic movement, which is the scapula moving along the thorax. And the second bit of the movement comes from the glenohumeral joint. So on the whole, if somebody lifts their hand up, such as that, a lot of the movement comes from the scapulothoracic joint and a lot remaining comes from the glenohumeral joint. So if somebody's got very little movement in the glenohumeral joint, they'll still be able to lift their hand up there because the scapula has rotated on the chest wall. And that you would see in an anatomy which does that. To identify movement purely from the glenohumeral joint, there are two ways one could do. One is to stop the scapula from rotating, or the second one is to hold the scapula in that plane and rotate. So if I want to examine how tight the glenohumeral joint is, I would get the patient to do that. And if they cannot do that, then the shoulder joint or the glenohumeral joint is stiff. The shoulder joint moves in two planes, the scapulothoracic joint and the glenohumeral joint. To see how much of movement one has from the glenohumeral joint, or to isolate the range, one test which is useful is the external rotation. This movement is purely from glenohumeral joint. In a patient with a frozen shoulder or osteoarthritis of the shoulder or any glenohumeral joint pathology, you would find the external rotation would be significantly reduced compared to the other side, i.e. the patient might not be able to both actively and passively externally rotate the shoulder compared to the other side. It's worth marking the bony anatomy. The first thing to feel for is the acromion process and the spinous process of the scapula. As we come along the front, the clavicle comes around here and the posterior border here, and the AC joint, which is along this line. And you can feel that with the prominent part, the AC joint. The coracoid process can be felt right underneath in this position. One of the interesting things about marking this is for injections into the subacromial space, AC joint, into the subcoracoid space if required. Prior to the consultation, it's important to be bare below the elbow and gel your hand prior to examining the patient. The first part of the examination is inspection. Inspect the muscles around the shoulder joint, the deltoid, the pec major, the trapezius. Also look for the hollow in the supraclavicular region and the infraclavicular region. Look at the sternoclavicular joints and see if there's any wasting or any difference in the shape of the muscle. Looking at the person from the back, one starts off with the supraspinatus fossa, which is well developed here, the muscle, the infraspinatus fossa, and the position at which the scapula lies on the chest wall. Don't forget to examine the spine to make sure that it is straight and there isn't any scoliosis or kyphosis. The second bit of the examination is the palpation. One's palpating for the sternoclavicular joint along the clavicle to feel if the patient's got any tenderness, to feel the AC joint, and if somebody has AC joint osteoarthritis, they have pain around the AC joint, the acromion anterior border and the posterior border. Then one palpates along the posterior border of the acromion, along the spine of the scapula, along the medial border of the scapula, working one's way down to the inferior angle of the scapula and the lateral border. It's worth palpating the cervical spine at the same time to see if there's any tenderness. The next part of the examination is movement. So the movements of the shoulder which we are going to look at would be flexion, extension, abduction, adduction, external rotation, and internal rotation. To look for flexion, we look at the range at which the shoulder joint moves. We compare it with the other side, so we get the patient to flex with the thumb pointing up, and you can see it flexes to about 150 degrees and bringing it down. And one can at the same time look at the scapulothoracic rhythm. The next movement is abduction along the scapular plane with the thumb pointing up, 160 degrees, and one looks at the scapulothoracic rhythm at the same time. The third movement to look for is external rotation with the elbow tucked into the waist. You get the patient to actively externally rotate, and you can compare it to the other side. External rotation here actively is about 70 degrees. Internal rotation is to ask the patient to get his hand or her hand behind his or her back. When one compares it to the other side. Fine. Adduction is getting the hand across the front of the chest. And extension is to get the hand behind as far as it can go. The things to look for whilst you're looking at examining the patient from the back is to look at the scapular setting. See, the scapula is slightly offset on the left side compared to the right. You're looking at the infraspinatus muscle bulk and the supraspinatus muscle bulk. Whilst looking for movement, we get the patient to flex the arm, flex the shoulder, all the way up. You're looking at the angle at which his shoulder flexes, and also at the scapulothoracic rhythm. So I get the patient to do this a couple of times, and one looks for the scapulothoracic rhythm. Coming to abduction along the plane of the scapula. We're also going to do internal rotation, where we get the patient to get his hands behind his or her back, and we're looking at the height of the thumb. So one can say thumb to T12 level, and it's equal on both sides. Whilst examining the range of movement, it's important one does the active movements first, followed by passive. Say, for example, for external rotation of the shoulder, one does active external rotation, which you get the patient to do, and then try and increase the rotation if you can on both sides. It's also important when testing for external rotation to do both sides at the same time to stop the patient from rotating his or her arm to increase the external rotation. So we're going to test the rotator cuff muscles. The muscles we're going to test is the supraspinatus to start with, which is tested with the arm along the plane of the scapula, thumb pointing down, and getting the patient to resist any downward force. Always feel for the muscle contraction, and this is the area of the supraspinatus where I'm feeling the muscle contract. I'm going to test the infraspinatus. Get the patient to flex the elbow and get the patient to push your thumb away against your thumb. And that tests the infraspinatus. This is the second test for the supraspinatus, where you get the patient to abduct the arm to about 90 degrees with the thumb pointing down and ask them to hold the hand up. While testing the supraspinatus, you feel for the supraspinatus muscle contracting. So we're going to test the subscapularis, and this is called the belly press. So what we're going to do is get you to put your hands on your tummy and push your tummy in as hard as you can. And what you're finding here is the elbow is sitting in good position and not pulled inside. The second test for subscapularis is to get the patient to turn around, get them to put their hand behind their back and lift the hand away from the back. And if the subscapularis is functioning, they'll be able to do this. And this is called Gerber's lift-off test. And Christian Gerber is a surgeon from Switzerland who's described this test. So we've done all the movements from the glenohumeral joint and the scapulothoracic joint. And as I mentioned, the shoulder movements come from both the glenohumeral and the scapulothoracic joint. So if someone has reduced movement of the shoulder, it could arise from lack of movement from the scapulothoracic joint. The way to assess the scapulothoracic joint for conditions such as long thoracic nerve or serratus anterior palsy is to ask the patient to lean against the wall with both hands. So we're testing for the long thoracic nerve, and what one would see is to look for winging of the scapula. And here you see the scapula is well set against, and you get the patient to lean forward and come back, and there's no winging of the scapula. And finally, before we conclude the examination, it's important one examines the cervical spine, the joint above the shoulder, and the joint below the elbow joint. Now we're going to do some special tests on the shoulder to look for pathological conditions. One of the most common conditions we tend to see in clinics is called impingement. Impingement is a condition where the supraspinatus impinges on the undersurface of the acromion, and it happens invariably when the patient flexes their shoulder and rotates it, and that produces pain along the region of the deltoid. The way to test that would be to get the patient to flex the arm to 90 degrees, flex the elbow, and rotate the hand down. Whilst carrying out this maneuver, if the patient has pain, it's worth asking them where the pain is, and they tend to point pain to be in the region of the deltoid. And that is a positive test for impingement. AC joint pain tends to be localized by the patient to that part, which is the AC joint. It doesn't radiate down, it tends to be localized to the AC joint. And the way it's tested is by doing the cross-adduction test, where one compresses the acromion to the clavicle, producing pain over the AC joint. The next test is to look for what's called a slap lesion, which is a superior labral tear. And that is by getting the patient to flex the shoulder to 90 degrees, turning the hand so that the thumb is pointing down, and asking the patient to hold the hand out there against resistance. That's the AC joint. And with O'Brien's test, with the thumb pointing down, if you ask the patient where it hurts, if they point to the AC joint, pain is arising from the AC joint and not from a slap tear. The second part of the test is to supinate the forearm. Ask them to hold the arm in that position and test it against resistance. The positive test it would be pain when the thumb is pointing down against resistance, and pain is relieved when it's tested with the thumb, with the forearm supinated. The next test is anterior apprehension, and one does that for anterior shoulder dislocations to see if the patient finds the position of the arm to be vulnerable, painful, or it would dislocate when put into that position. The reason for that is the with the anterior dislocation, one tears the labrum or the lining of the front of the glenoid. And what we are trying to achieve, if that is the glenoid, is to bring the humeral head here to see if we can get it into that position, and that is painful for a patient with a labral tear. The way to do that would be to get them into the vulnerable position, which is abduction of the shoulder and externally rotating the shoulder and looking at the patient's face when you try and push the shoulder forward, and if they are uncomfortable, you see them wince, and that is a positive test for apprehension. On this young lady, we also know that she has problems with the left shoulder, and she finds it difficult when she swims. And I'm going to try the anterior apprehension test, and we're going to bring the arm to 90 degrees, externally rotate, and you can see her face. She doesn't like that vulnerable position. Bring it back. And you can also see the way the shoulder moves in that way she's trying to protect. Thank you to James for allowing us to examine his shoulder and to demonstrate the muscle power and muscle examination. And thanks to Fenella for letting us examine her shoulder and also look for pathological lesions and to show certain pathologies which are commonly seen in clinic. Thank you, both of you.